So today we saw a real-world abstract presented on this very favorable IMDC risk category, and the very favorable are patients that were more than 3 years from time of diagnosis to initiation of systemic therapy with no visceral metastases. And so those are patients that had a nephrectomy and then had indolent disease for a period of time and are only starting systemic therapy at least 3 years out. And they found that patients in that group that received doublet immunotherapy, so ipi-nivo, had a worse overall survival than the TKI regimens. Again, it was a small cohort, and we don't know the full circumstances under which patients were recommended to undergo IO-IO. But in general, we know that patients with favorable and very favorable are recommended to have a TKI-based regimen. IO-TKI, are the 3 options generally for favorable risk that are recommended if you're following guidelines. There's weaker evidence for IO-IO in that setting. Maybe part of it is the expected high rate of toxicity that you can see with IO-IO in that setting. And so I think, in the current space where we are now for favorable and very favorable, we're still considering TKI-based regimens.